Great. Well, thank you, Christina, for that very kind introduction. Really kind of you. Christina's a great friend. She's looked after me lots. So, so here we go. We're going to talk about the management of mild asthma, both in the school-aged and the preschool child. And then we'll move on to talking about biologics in severe asthma. So for school-aged children, we mean children aged between 5 and 16. And before you go anywhere near any treatment for any child with asthma, the first thing that must be done, and this is really, really important, and I am going to spend time on it because it's so important, is you've got to make sure the child in front of you has really got asthma. Confirming the diagnosis is really essential. And we no longer just say a child has asthma from the history and examination. That's not enough. We have to do objective tests to really confirm that that asthma is present in the child in front of you and that we're avoiding misdiagnosis, wrong diagnosis, underdiagnosis, overdiagnosis. So you have to do some tests. GINA say that the best test or the test that should be done is spirometry, looking for airway obstruction and then reversibility, evidence of reversible airflow obstruction. If you can't do spirometry, then evidence of peak flow reversibility is also acceptable. And it's not just the numbers on spirometry. Obviously, you need to look for airflow obstruction, which is reversible, but looking at the flow volume loop is really, really essential. So the flow volume loop on the right, even if that child has got a history that sounds like asthma, is not going to be asthma, right? It's so obvious that is not the flow volume loop of a child with reversible airflow obstruction. And I'm laboring this point because just 3 weeks ago, we had a 14-year-old boy that came to the Brompton who had a history of difficulty in breathing, noisy breathing, and had been given inhalers for asthma for 6 months. And this was what he had. He had a mucoepidermoid carcinoma in his trachea. So it's being done all the time. Asthma is being wrongly diagnosed and too easily diagnosed just from a history. And we really have to get away from that and do some tests. So this is an algorithm that might be useful for you to use to help work out whether a child has asthma. If you've got a patient in front of you with respiratory symptoms, the first question is, do they even sound typical of asthma? And if they don't, then please look for alternatives and find out what that child has got, because it's not asthma. But if on detailed history taking and examination, you feel this really does sound like asthma, you do not at that point prescribe inhalers. We don't do that anymore. You need to do some form of objective testing, ideally spirometry or peak flow reversibility testing, to see if it supports the diagnosis of asthma. If it does, then you think about treatments. And I just wanted to highlight this, just published a couple of months ago in the ERJ. It's the guidelines, ERS guidelines for asthma diagnosis in school-aged children. And so if you, again, they're saying if you've got a school-aged child with symptoms that are consistent with asthma, the first thing must be to do some objective testing, either lung function testing or exhaled nitric oxide testing if spirometry is normal. I'm not going to talk through this algorithm because the talk is about treatment, but please do look at these guidelines, refer to them and the GINA guidelines, and please do some objective testing to confirm asthma. One of the tests that's mentioned in the ERS guidelines is exhaled nitric oxide, which is a really useful, if you have it available, a really useful non-invasive test of type 2 airway inflammation. And if it's elevated, it can be helpful in supporting a diagnosis of asthma. But just bear in mind that the child needs to be steroid naive. If they're being treated with steroids, the exhaled nitric oxide may come down. It's a steroid sensitive marker. So for a child who's on steroids, you can't make a diagnosis of asthma. But if they're not on treatment, if it's elevated, it would support asthma. But also just remember that just atopy without asthma can result in an elevated exhaled nitric oxide. So there's no gold standard test, but you need to use supportive tests to confirm the diagnosis. And the final supportive test is looking for air allergen sensitization, whether that's by skin prick testing or blood tests. Really, really important. Okay. So then you've confirmed the diagnosis, you've got reversible airflow obstruction. how do you treat it? Well, the underlying pathology in children with mild asthma, which is what we're talking about, is eosinophilic allergic inflammation in the airways with bronchoconstriction from smooth muscle contraction. So that's what you need to target with your treatment. You must target the underlying airway inflammation, which is eosinophilic, and that has to be targeted with inhaled corticosteroids. And then for the smooth muscle contraction, to reverse that, you need short-acting or you need some form of bronchodilator therapy. But the anti-inflammatory therapy is critical. No matter how mild the disease, you must use anti-inflammatories in children, school-aged children, with a confirmed diagnosis of asthma. That's really, really important. So if you've made a diagnosis of asthma, you must not give any child just as required short-acting bronchodilators. We do not do that anymore, okay? We must prescribe some form of regular anti-inflammatory therapy. And that can be very low dose inhaled steroids. That the dose does not matter, but they must have anti-inflammatory on board. And then if they're symptomatic, they can have short-acting bronchodilators, and you can adjust the dose depending on the amount of symptoms they're getting. Please do not just prescribe short-acting bronchodilators for children with asthma, no matter how mild. We don't do that anymore. And the reason we don't do that is because the anti-inflammatory therapy is critical to prevent them from having severe attacks and fatal attacks. And this is the data that tells you that anti-inflammatories are critical. So inhaled corticosteroids became widely available in the late 80s and early 90s. But this graph shows you that in children and young adults globally, we have not managed to remove asthma mortality despite having anti-inflammatories. And if you home in on the last 2 decades, you can see the rate of asthma deaths has plateaued. Why have they not gone down? The majority of children should be controlled on basic anti-inflammatory treatment. The reason for this is because we've been giving as required short-acting bronchodilators. That's a big mistake. All patients with asthma must be on some form of anti-inflammatory treatment. And on top of that, if you're going to prescribe an inhaler, please, please, please make sure you've got the basics of asthma management right. Explain to the child and the family why you're giving them the inhaler that you're giving, the importance of the anti-inflammatory treatment. Please show them how to take the treatment. Children should not be using an inhaler without a spacer. They must have the appropriate spacer with a mask if they're young, up to about the age of 4, and then beyond that, it's a spacer with a mouthpiece. If we don't get these basics right, the kids won't get any treatment and they're not going to get better, okay? And you must never, ever, ever give any child an MDI without a spacer. That should land you in prison. It's a crime because they're not going to take it properly. Really important to give all MDIs with a spacer, and to make sure they understand why they need to take their treatment so they will be adherent and so they don't have asthma attacks. And please give them a really clear action plan of what they must do if they develop symptoms, and if their symptoms are getting worse, when they should seek help, what type of doses they should be using, which inhalers they should use if they're symptomatic. If we can get these basics right, by far and away, we will get rid of asthma, essentially. We can treat asthma in school-aged children if we get these 3 basics right. And some of it actually, I think, is our fault as clinicians. We give the families really complicated regimes. We say, use this blue inhaler, use this orange inhaler, use this purple inhaler. We give them different devices, we give them different regimes, and they get really confused. And the only inhaler that ever helps them is the blue one. So why would they take a brown one or an orange one, or the one that they really need with the inhaled corticosteroid, if actually the one that benefits them is the blue one? It makes no sense. So we need to change our way of thinking and our way of prescribing. And we need to make these children's asthma regimes simple. Single inhaler. Why are we not doing that? If it's the blue inhaler that's giving them relief, then why can we not give them a single inhaler which has both the anti-inflammatory treatment and both an immediate bronchodilator effect and a long-acting bronchodilator effect? Well, we can do that. And we can do that with budesonide formoterol or other inhaled corticosteroid formoterol combined inhalers. And that would be called single inhaler maintenance and reliever therapy, or SMART therapy. I really, really encourage you to adopt this approach, especially for adolescents age 12 and above with mild asthma. And I'll show you the data that supports this approach. So you just give them a single inhaler, and whenever they've got symptoms, this is all they have to use. There's no blue, there's no brown, there's no orange. If you're symptomatic, just take this inhaler and you will feel better. And at least they're getting anti-inflammatory treatment at the same time. That's what's going to save them from having an attack. And using this regime does improve asthma outcomes while potentially actually reducing the amount of inhaled steroid. So where's the data to support this approach? Well, the data for adolescents came from the Sigma 1 and the Sigma 2 trials, which were done in adults and adolescents. And it was 52-week randomized trial, and the adolescents got randomized to either twice daily maintenance inhaled steroids with SABA, or just as required combination budesonide formoterol, or as required short-acting beta agonist, which we should not be using, but that was used in this trial. And you can see why we should not be using short-acting beta agonist as required, because the blue bar represents that group and they had the highest number of attacks. The primary outcome here was attacks, and that's on the y-axis. But what was really nice was that the children that either got low-dose maintenance inhaled steroids with as required short-acting bronchodilator, or just as required budesonide formoterol combination, they did equally well. So those two regimes are as good as each other for mild asthma in adolescents. So please, please consider the approach if you can in adolescents. And GINA actually suggests this for adolescents. They say that the preferred approach for children with mild asthma, which would be steps 1 and 2, is as needed inhaled corticosteroid with formoterol. That's whenever you're symptomatic, just use that. That's your reliever, that's your preventer, that's your only inhaler. If the child gets slightly more symptoms, then you can say that use the combined preparation twice daily, and then your reliever is the same thing, just when you need it. Now, that's fine for adolescents, but the problem for us in the UK, and the problem in general for younger children between the ages of 6 and 11, is this regime has not yet been shown in clinical trials to be effective in 6 to 11-year-olds. So it can't be recommended at the moment for younger children. And the problem for us in the UK is we can't get the combination of budesonide formoterol in an MDI. We only have it as a turbohaler. So technique is really important. And often our younger children below the age of 9 can't do it properly with the turbohaler. But if you've got access to an MDI formulation, then I really, really think this with this MDI and spacer regime is absolutely a priority for adolescents. The other approach you can take is either twice daily low dose maintenance with as required bronchodilator, or if you haven't got the combination preparation, the key here is to make sure the child gets anti-inflammatory treatment. Give 2 inhalers, but just say take both when you're symptomatic. There is no such thing as just take the blue anymore. We don't do that. If you've got symptoms, take the blue and the brown. So at least they're getting some anti-inflammatory treatment on board. The difficulty comes to the 6 to 11-year-olds. We don't have trials of SMART regime in 6 to 11-year-olds. It's a really urgent unmet need, and we need the trials. So GINA say that for 6 to 11-year-olds, you should give them an inhaled corticosteroid inhaler and a short-acting bronchodilator, and say whenever you're symptomatic, take both. Or you do twice daily low-dose maintenance inhaled steroids, and then your as needed is the blue. But if you can get the combination device, use that as your reliever, just so you're always getting anti-inflammatory on board, okay? So they're the options for the school-age children, and I hope you've got the message that please consider SMART, a single inhaler for everything, and please do not prescribe just a short-acting bronchodilator. That should not be done anymore, no matter how mild the asthma. So what do we do, for preschool children, aged between 1 and 5 years? Well, this is an algorithm that Andy Bush, who's going to be presenting after me, and I published, which is sort of summarizes our current approach to these patients. And I'm going to talk you through this so that to give you a summary of how we should be doing it. And just like for school-aged children, the most important thing that you must do before going anywhere near a prescription pad for preschool wheezers is confirm they've got wheeze and make sure that there's no alternative diagnosis that needs to be treated. This is really, really important for the preschoolers because there are often associated other diagnoses like aspiration, gastroesophageal reflux that can be contributing to symptoms which really do not need treatment with inhalers. So really do think about that. Think about the red flags. Have the symptoms been present from birth? That's not right for typical wheezing. Have they got a wet cough? Are they failing to thrive? On examination, is there something just not quite right? And if they're not responding to treatment, then either they just haven't got wheeze or they're not taking it properly. Okay, now for the preschool wheezers, even when you've confirmed that the child in front of you has definitely got wheeze, you're happy this child has got preschool wheeze and nothing else, you do not prescribe treatment straight away. We don't do that anymore. We do objective tests to identify the type of wheezing they've got to target treatment. This is really, really important. And your questions in your head should be, is this child's wheeze atopic, type 2 eosinophilic? How do you answer that? Well, you must do aeroallergen sensitization and you must do a full blood count to look for blood eosinophils when the child is well, not during an acute exacerbation. And if the blood eosinophils are elevated, or if they're sensitized to aeroallergen, they've got atopic eosinophilic wheeze. The next question should be, actually, is this non-atopic, predominantly infection-driven wheeze? In which case, those two tests will be negative, but you need to do the tests to show that. And you'll have a very, very seasonal pattern with distinct episodes and rattly noises rather than true wheeze. Is it neither of those? That's a possibility. And if at all possible, do again, try and do some form of spirometry or look for evidence of bronchodilator reversibility, even in the preschoolers, if you possibly can. So what do you do then once you've done those tests and you've identified what we've called the treatable traits? So if you've got a child with either atopy and or elevated blood eosinophils, you definitely should try low-dose inhaled steroids because they have what seems like eosinophilic airway inflammation, so you target it with inhaled steroids. But give it as a trial for 6 to 12 weeks. Make sure, again, you show them how to take it properly, and then stop and see what happens. And the first question is, did it work while they were on it? And if it didn't, either they weren't taking it, or they weren't taking it properly, or they haven't got atopic eosinophilic wheeze, and consider something else. But if they improved and then get worse when you stop, then definitely they should be continuing on maintenance inhaled steroids at the lowest dose possible to prevent attacks. What if it feels like a more sort of infection-induced wheeze picture? They're non-atopic, eosinophils are normal. Well, then ideally we need to look for the infection. And if possible, we would try and take a sputum sample if at all possible. But if not, then you can have a trial of 2 to 4 weeks of antibiotics to see if it works. But it is a trial and it's for a restricted period. And if it's neither of those, then really this child has just got bronchoconstriction at set times. Probably a lot of them have just got small airways. And in that case, in this age group, you can give just short-acting bronchodilator only when they're symptomatic. But they've got to do it properly. There's no point in them eating their inhaler. There's no point in them drinking their inhaler. You've got to show them how to do the treatment properly. I cannot emphasize this enough. Really, really important. And adherence is as important in preschool children as school age. You might think in the preschoolers, oh, the parents are going to give it. Of course, the parents are going to give it. They're so reliable. Well, they're not. This is data from children who had really severe wheeze who were in a clinical trial. We gave them electronic monitors to assess their adherence. And of the 48 that we gave out, only 36 were ever returned. A year later, 12 just disappeared. The families came back, the inhaler monitor was lost, which means they probably weren't giving it. And of the ones that did return their monitors, the median adherence was only 64%. And what do we expect? At least 80% is good adherence. So please do not assume that just because it's a preschooler, they'll get their treatment. They won't. And you've got to really emphasize the importance of adherence to treatment if you want to see benefit, and don't just keep escalating doses. And the one thing to say is if they've got good adherence and they've got the atopic phenotype, they will improve. But if they're non-atopic, even if they've got good adherence, preschoolers do not improve. So don't just keep plowing on with inhaled steroids. If they're taking their treatment and they're not improving, just question the underlying phenotype. Is it really atopic eosinophilic wheeze, or is it something else? And investigate and target your treatment appropriately. Don't just, this preschool wheeze age group is very different in that respect. They're not all, by any stretch of the imagination, atopic eosinophilic allergic. Only about a third are that phenotype. A lot more than half are non-atopic. Okay, so what have we discussed? Well, for school age children, the first thing before you go anywhere near treatment is to make sure you do objective tests to confirm a diagnosis of asthma. If you've confirmed it, then you can either use low-dose maintenance inhaled steroids with short-acting bronchodilator, but I would say try and consider SMART, especially for adolescents who never want to take their treatment and they will only take it when they're symptomatic. So please, please use SMART. Or use ICS and SABA PRN. So whenever you take your SABA, you take your ICS at the same time. And don't forget the basics, so, so important. If we get that right, I think more than 99% of our patients would be fine. For the preschool age group, again, confirm the diagnosis and do objective tests. Don't just give out inhalers. Work out whether the child in front of you has got atopy, has got elevated blood eosinophils, and if they have, then give maintenance inhaled steroids, or you can try a leukotriene receptor antagonist for that phenotype either. But my preference is inhaled corticosteroids because I think they work better. If you don't think it's that phenotype, then look for infection and give targeted antibiotics for a set period, not forever and ever, just for a very 2 to 4 week set period, and see if they improve. And if it's just isolated wheeze, then for this age group, as required, short-acting bronchodilators are good. But the basics are as important no matter what the age, because if they're not taking it properly, it's not going to work. Okay. Did you want me to carry on, Christina, or?